Thank you, sir.
We invite Dr. Debolina Deb. She'll be presenting her paper on association of endothelial in NOS polymorphism in babies with ROP.
Good morning, respected judges and everyone. My name is Dr. Debolina. I'll be presenting on the association of eNOS polymorphism in babies developing ROP. My co-guides are Dr. Suhasa and Dr. Mutaya, sir. I have no financial conflicts of interest. So coming to the introduction, we know that preterm babies, specifically with a gestational age of less than 34 weeks and birth weight less than 2 kg, they are prone to develop ROP, specifically if they have had a prolonged mechanical ventilation associated with sepsis, anemia, bronchopulmonary dysplasia, intraventricular hemorrhage, and multiple transfusions. They have a susceptibility of developing ROP. But under the similar conditions, we see some babies who do not develop ROP also. That leads to our question, perhaps there's a role of some genetic predisposition or not. So I'm specifically talking about the eNOS gene, which is seen in the short arm of the chromosome 7. And I'm going to talk about the two SNPs, that is the 786C and the 894, which is seen in the promoter region and exon gene of the 7q. And it helps in translating the eNOS protein, that is, converts the L-arginine into citrulline, and it also releases the nitric oxide. Now, why am I so much interested in the nitric oxide is because it plays a great role in the vascular smooth muscles and leads to the vasodilatation, and it perhaps plays a role during the angiogenesis process of ROP and the vascular development. So coming to the aim of my study is to study the polymorphism in the eNOS 786 and the 894 gene in preterm babies who develop ROP and those who do not develop, and compare the two. Ours was a prospective observational study done in a tertiary care center in South India over a duration of 1 year. We included 103 preterm babies with gestational age less than 34 weeks and birth weight less than 1750 grams. For them, we collected the buccal swabs to extract the DNA, following which we ran them for the PCR, and after getting the PCR products, they underwent microplate restriction fragment length polymorphism. For eNOS 786, we used the MS1 enzyme, and eNOS 894, we used the BAN2 enzyme. So this was the scoring for the eNOS 786, which had the base pair length of around 180 base pair, and accordingly they were analyzed as TT, that is a wild type, TC being the heterozygous type, and the mutant type was the CC. And for the 894, the base pair size was 258. Again, they were divided into the GG, the wild type, heterozygous GT, and the mutant TT type. Coming to the results, out of the 103 preterm babies, 24% developed ROP, out of which 9% required some kind of treatment, mostly with laser photocoagulation. Coming to the demographic risk factors associated, we saw the babies with ROP had a lower gestational age, that is 28 weeks, as opposed to the 31 weeks in the ones with no ROP. The ones with ROP again had a lower birth weight. They had a prolonged mechanical ventilation, and also history of blood transfusion was greater in the babies developing ROP, and these were statistically significant. Now coming to the SNP analysis, so what we saw that when we studied the eNOS T786 gene, we saw that a greater number of babies with ROP had a greater number of C allele, that was the mutant type, and these babies had a 3.16 times greater risk factor, odds risk ratio of developing ROP with a p-value significant of 0.002. Whereas, coming to the analysis for the eNOS G894 gene, we saw that the babies with, the mutant T allele type had 3 times greater odds risk of developing ROP, and that also had a risk, the p-value of 0.02. So coming to the discussion, we know that ROP is a passive proliferative disorder seen in preterm babies, and they have multifactorial risk factors associated for developing it. But there's also some genetic predisposition postulated. Until date, we have seen a lot of studies done on VEGF, IGF-1, BDNF, and ACE. But I'm specifically going to be talking about the eNOS gene. Coming to the studies that have been done till now, There have been studied by Yu et al. Where they've seen the analysis of the NOS3 polymorphism in oxygen therapy, and they have found a protective role in the eNOS 786, that is the C allele, in the babies developing ROP. Whereas the study by Yanamandra et al., they saw both the 786C and the 894T. These are the mutant types that were there seen to be associated with ROP in both the Caucasian and the African American babies. The study by Michalek et al., they also found that the TT genotype and the T allele, that is the mutant type, were associated with eNOS. I'll just wrap it up quickly. So there were other studies where they did not find any difference in the genotype allele distribution between the ROP and the no ROP group, and there was a meta-analysis also where they saw that there was not much difference between the 786 particular polymorphism and ROP. But there was the study by Ilga et al. Where they found a positive correlation between the eNOS, that is the 894, SNP and ROP, which is similar to our study.
Please conclude.
I'll wrap it up. So to conclude, basically there's no study done on any Indian population describing the eNOS polymorphisms. So we found that amongst the subset of South Indian preterm babies, the eNOS 786C, that is the mutant type, and the T894, again the mutant type, has a greater risk, around 3 times higher odds ratio of developing ROP. Thank you.